Hi guys, today I'm gonna talk about doctors A, B, C, D, E, F, G, but mainly focusing on airway and breathing, and also going through some oxygen devices and about respiratory failure. So I think this is a core knowledge that we should all know. Danger response, send for help, airway, and these are some of the things that we assess. And others should take a few seconds. It shouldn't take anything more than this. And then we also look, listen, feel. So we also listen for breath sounds, any crackers, whether that's pneumonia, and of course all the other vitals. And we should always have some differential diagnosis in mind. So some people like to include just A, B, C. Some people include D, and E, F, G is also some people do it, some people don't. But this is of course also important in conditions like APO, where the patients are overloaded or other kinds of failure, and also glucose and ketones if the patient is having a seizure. It could be hyperglycemia if they're having increased work of breathing as well. So I always go to check and also do a VBG/ABG. So, and then this is just some basic anatomy of the respiratory tract. It can be divided into the upper and lower airways, which you can see here. Or it can also be divided through the conducting or the respiratory zone, where the conducting zone transport gases and the respiratory zone exchanges gases with the blood. So gas and blood, which is also what forms the VQ ratio, the ventilation over perfusion. So upper respiratory tract, we get infections like pharyngitis, laryngitis, which is the voice box, tonsillitis, sinusitis, and also the ear, nose, throat basically. And then lower respiratory tract would be more of the lungs, the pneumonia, bronchitis, tuberculosis, lung cancer, and obstructive airway diseases like COPD and asthma. Okay, so let's start off with oxygen therapy. So we can see here what constitutes respiratory failure. So it's a PaO2 of less than 60. And there are two types, oxygenation failure, the first type, or type 2, the ventilation failure, where other than low oxygen, there's also high carbon dioxide here. And these are some of the conditions. So you can see here that, let me see what I should talk about. Yeah, this is an important note as well. It can occur in multi-organ failure and not just respiratory conditions. And I'll talk about non-invasive ventilation later. So CPAP and BPAP. And CPAP is more for type 1 respiratory failure because it helps with APO, and type 2 is for mostly BiPAP, which is COPD. So you can remember COPD for breathing, so breathing for B, and then airway is for circulation, so CPAP. So starting off with the standard oxygen devices for oxygen therapy, we are targeting SpO2 of 92 to 96%, as you can see here. But if they have COPD or chronic CO2 retention, you will target 88 to 92%. So COPD is actually very common. So, okay, I shouldn't say this, but yeah, it's pretty common. So a lot of people, we're actually targeting lower oxygen sets, but of course, we should always give oxygen to anyone in distress. So starting off with the standard nasal prongs, which is often a O2 flow of 1 to 4 liters per minute and a FiO2 of 0.24 to 0.36, which is also 24 to 36% basically. And there's also a higher form of nasal prongs, high flow nasal prongs, which is a FiO2 of more than 0.35 usually. Venturi mass is the next one, which is 2 to 15 liters per minute, but it's often only just given as 2 to 4 liters or 24 to 28%. So with every 1% 1 liters increase in oxygen flow, there is around a 4% increase in FiO2. So these two are usually used in type 2 respiratory failure risk, and when there's the target O2 sets are less than 88%, which is what we are targeting for someone with type 2 respiratory failure risk or COPD. So in this kind of cases, we use 2 to 4 liters of ventilator mask or 1 to 2 liters of nasal prongs, so the lower setting. And with the higher setting, we can see here 2 to 4 liters of nasal prongs. We use it in someone with no type 2 respiratory failure risk, but has O2 sets that is pretty low of 85 to 91%, so like lower than the target oxygen for a normal person of 92 to 96%. And then if their O2 sets are even lower, which is less than 85%, and someone where we're targeting more than 92%, you can see how sick they are. Often they also need senior clinicians to review, and probably ICU as well. So if they are less than 85%, we put them on 4 liters per minute of nasal prongs or high flow nasal prongs of more than 0.35 FiO2, which is basically high flow nasal prongs. And we also put them on simple face masks of 5 to 10 liters per minute or 100% non-rebreather reservoir mask of 15 liters per minute. So all these are kind of hard to see with just words, but I thought it'd be good to put everything together in a picture with more details, and I'll show you some pictures now. So let me just see, what is it? Yep. We've talked about this, and later I can talk a bit more about non-invasive ventilation, CPAP and BPAP, and also invasive ventilation, which includes the endotracheal tube and tracheostomy. And because I like airway and things, this is what I found from reading up about a difficult airway. So there are 3 steps, usually the back mask valve ventilation, which can be used for someone with an intact gag reflex. And then the supraglottic airway, SGA, which often includes the LMA, which can also be used for intubation and can deliver general anesthesia as well. And then endotracheal intubation, ETT, used with someone with who's unconscious and with ongoing paralysis and sedation. So this allows for high positive pressure ventilation, PPV, but also has some side effects. As you can see here, respiratory alkalosis, reduced cerebral perfusion, and barotrauma. I'm just to get this orange up. And the last resort is actually surgical airway. So it's in the case of can't intubate, can't oxygenate, and of course you also call for help. And there's ongoing trials of the supraglottic or endotracheal airways. So this will be the infraglottic airway surgical, where we bypass the upper respiratory tract, and usually is the cricothyroidotomy, which is often performed in an emergency. The tracheotomy is only, the trachea tube is only done usually in a controlled environment, and is usually planned, so not done in an emergency, and it's more for long-term mechanical ventilation. Okay, so let's just have a look at all these notes, which I've never really read. So this is basically a summary. So type 1 is for oxygenation, and type 2 is for ventilation. Yeah, okay. Yeah, this is a good diagram, oxygenation and then ventilation. Okay. This is also an important concept, the AA gradient, but we'll probably talk about that in another time. So these are the 5 causes of hypoxic which is like reduced FiO2, hypoventilation, VQ mismatch, which is ventilation over perfusion, and diffusion impairment or shunt, which hyposigmia. That's not correct if it's a gut shunt. So you can take some time to read through these. You can pause here and then have a look. But yeah, VQ mismatch is also another cause that we can talk about it another time. Core concept, VQ mismatch. You can see here there's a reduced perfusion and this reduced ventilation, and this is another core concept. AA gradient. Okay. So these are some of the causes of type 1 and type 2 respiratory failure. Sometimes there can also be a mix of both. So yeah, so these are the 5 causes of oxygenation, which we just talked about earlier. Okay, and yeah, this normal AA gradient. So this is the pros and cons of each oxygen devices. So I haven't actually read any of this, but let's see. Nasal prongs are probably the ones most used because they cause less claustrophobia and the patient can talk and eat as well. So there's often greater compliance. But of course, if the patient needs more than that, we have to titrate them to a different mask. The different concepts, PO2, SaO2, and CaO2. So you can see that SaO2 is a direct measure versus SpO2, which is indirect. Yeah, the goals of oxygen therapy and other tips would be to sit patient up, encourage deep breathing, gust cough, analgesia, and check for agitation. So factors causing a shift in the O2 curve, there's another concept, but this is just a short summary. And DLCO, which is diffusion affected by area, diffusion constant, partial pressure difference, and thickness, which is inversely proportional. So increased DLCO is found in pulmonary bleed, polycythemia, malshunt, and exercise and supine position, while decreased DLCO is found in emphysema, ILD, pulmonary hypertension, anemia. So these are important to take note of, as they can let us have a better idea of what our differentials are, especially when a respiratory function test is done. Okay, and now the pictures that I was talking about. So low flow delivery, we were talking about nasal prongs, Hudson mask, and non-rebreather, and this is what they look like. And high flow oxygen, we have the venturi mask. Let's see if I can make it. The back valve mask, which is the first step of airway emergencies, and the high flow nasal prongs. So this is what they look like. So venturi masks are only used for COPD, so allows for accurate control of FiO2, and back mask is for unconscious patients, but also patients with respiratory distress. Yeah, and high flow nasal prong is often a step down for non-invasive ventilation, the BiPAP and CPAP that we talked about earlier. Okay, so you can see here a step up from prongs to Hudson to non-rebreather. Yep. Okay. So CPAP and BiPAP. B for breathing, type 1 respiratory failure for CPAP, and type 2, which is COPD for BiPAP. But often BiPAP is more comfortable and also used for type 1 respiratory failure because there's no need usually for intubation. Yeah. Yeah, so there's two different pressures here, the inspiratory and expiratory pressures, plus the positive support or something.